Hello everyone, this is going to be a short talk on von Willebrand disease and hemophilia. I am Robert Rella and I am a third-year medical student, and I prepared this talk as part of my pediatrics rotation, specifically hematology oncology. So let's start with von Willebrand disease. Commonly, this is a disease that you can see in women, whereas hemophilia is more commonly seen in men because hemophilia A and B are the more common types, and those are X-linked, so that means they're more prominent in men. So usually if you see a woman with a bleeding disorder, you want to start thinking von Willebrand disease and then be proven otherwise. So let's just review how clots form. So first, we have an endothelial defect. This is a blood vessel. We have an endothelial defect, and subendothelial collagen, right, is exposed, and this activates von Willebrand factor. Von Willebrand factor binds to the subendothelial collagen through these glycoproteins that aren't depicted here, but von Willebrand factor binds to platelets via GP1B, and then platelets bind to platelets via fibrinogen and also via GP2B3A. So first what happens is the platelet plug forms. This is the platelet plug, activated aggregated platelets. And then after that, the clotting cascade comes and forms a more stable clot. So first we have a platelet plug, and then the coagulation cascade forms a more stable clot over. But bleeding is initially stopped by platelets and then fortified by the coagulation cascade. This is the coagulation cascade. It's a lot, but it's relatively simple. So there's an intrinsic pathway, there's an extrinsic pathway, and there's a final common pathway. And this is how we end up with a cross-linked fibrin clot over the wound, okay? So the intrinsic pathway, damaged surface, is what starts it, and then the extrinsic pathway is trauma. This is, vague, but what is important about this for this level of talk is the extrinsic pathway is timed with the prothrombin time, or PT, and the intrinsic pathway is timed with the activated partial thromboplastin time, APTT. And this and we can time this clinically with assays. And so if it's longer or shorter, it's never really shorter, but if it's longer, then we can tell that, hey, this isn't working so fast. What's going on? There's probably too little. And the PT is usually about 15 seconds, and the APTT is about 30 in general. And they both converge on factor 10, get 10A, and then get thrombin, fibrin clot. Moving on. So some general information about von Willebrand disease. It's considered an intrinsic pathway coagulation defect. Why is that? If it has to do with platelets, right? Von Willebrand factor binds to platelets. Why does it have anything to do with the intrinsic pathway? Well, as we saw earlier, I didn't point it out, but von Willebrand factor carries and protects factor VIII. And so in the absence of von Willebrand factor, factor VIII is no longer carried or protected by von Willebrand factor. And so the levels of factor VIII will subsequently go down and the PTT will prolong. And then, therefore, this is a defect of the intrinsic coagulation cascade. A von Willebrand factor is a defect in platelet plug formation. Why? Because decreased levels of von Willebrand factor leads to a defect in platelet aggregation. Platelet to von Willebrand factor adhesion, right? So we have activation, adhesion, and aggregation. Those are the three steps of a platelet plug: activation, adhesion, and aggregation. So the inheritance pattern of von Willebrand disease, what is it? Well, we already said women can get it. So it is autosomal, right? It is on any chromosome other than the sex chromosomes. That's what autosomal means. And von Willebrand disease is a dominant disorder, meaning you only need one copy of the gene to have the disease. It is in general a mild disease, but it is the most common inherited bleeding disorder amongst all people. We diagnose it with the ristocetin platelet aggregation assay. What will we see on this ristocetin platelet aggregation assay? We take someone's blood, we spin it down, we get the platelets, we put it in this assay. What are we going to see? No aggregation. They don't stick together, right? Von Willebrand factor helps that. When von Willebrand factor is gone, platelets do not stick together as well as they normally do. We treat it with desmopressin. This is, as I found out after speaking and giving this talk to my professor, That is not routine management anymore as much as giving von Willebrand factor concentrates. This is the mainstay in therapy. Von Willebrand factor concentrates. You can live an almost normal life with just replacing the lost von Willebrand factor. So von Willebrand concentrate, it's like if you don't have, it's just like putting gas in the car. The car burns it up, you put more gas in. Soon, kids won't even know what gas is, but whatever. All right, so desmopressin, it causes stored von Willebrand factor to be released from endothelial cells. Makes sense. So desmopressin takes what you do have and makes you release it, and it comes from and is stored in endothelial cells. So there are four types of, there are three large types of von Willebrand factor. These can be broken down into many subtypes, but the easiest way, I think, is to think about it as a quantitative deficiency of von Willebrand factor. So partial quantitative deficiency, type 1, and then type 3 is virtually complete deficiency. In terms of gene mutations, if you want to think about it, type 1 could be inheriting one copy of the defective gene, and then type 3 would be inheriting 2 copies of the defective gene. And then qualitative means that you have it, but it just doesn't behave as normally as it should. And then type 2, can be it's subdivided into 4 further types. So 2A, 2B, M, and N. And these are, as far as, they're not very important to this talk, and I'm just not going to go through those. If you want, you can pause the video, go through them, learn them. But I think anyone who clinically would be making the decision to distinguish between these types is probably not watching this, but if you would like to, there they are. I don't understand them enough to teach them. All right, so I do understand this, and this is what USMLE tests love to do. So we have von Willebrand disease. They love to give you a chart, and they love to give you arrows, and they love to say, which of the following expected changes is likely to be seen in von Willebrand disease? So before we go further, here's a coagulation cascade pathway. Again, von Willebrand factor is not in the coagulation cascade pathway, but it does carry and protect factor 8, which is part of the coagulation cascade, okay? And it's part of the intrinsic pathway, which is the APTT. So knowing that, and also we'll get to another thing here, right here with bleeding time. So what is the bleeding time in von Willebrand disease? Increased, decreased, or normal? Sorry, there was a gnat. I had to kill it. The bleeding time is increased. Why is the bleeding time increased? Is it because factor 8 is missing? No, it does not. If you said yes, wrong. The bleeding time is increased in von Willebrand disease because it is a platelet plug. It is primarily a platelet plug disorder. Okay, so platelets are what stop bleeding. Clots are what stabilize the platelet plug for longer term hemostasis. Initial bleeding is stopped by platelet aggregation. Initial bleeding is stopped by platelet aggregation. Okay, so if the platelets can't aggregate, the bleeding time is going to be increased. Okay, now that is moving, that is that concept. So now the rest of this is kind of more straightforward. The platelet count in von Willebrand disease, increase, decrease, normal. It's normal. There's nothing wrong with the platelets. Von Willebrand factor is a protein, or a glycoprotein. It is a substance. It is not a cell. It is an accessory to platelets. It doesn't affect platelets at all. It is something that interacts with platelets, but it does not affect platelets. Okay. PT time is normal. Why is the PT time normal? Because here's the PT time. It times the extrinsic pathway. Is there anything that has to do with von Willebrand factor in the extrinsic pathway? No. So it is normal. PTT. PTT and APTT are synonymous. Okay. The A is just for activated, but if you say PTT, they're going to know what you mean. The PTT is what? Increased, normal, or decreased? It's prolonged. Increased. Why? Because von Willebrand factor, even though it's not part of the intrinsic pathway, it carries factor 8. And when von Willebrand is gone, factor 8 is decreased, intrinsic pathway is prolonged. All right, moving on. Let's go to hemophilia. The classic picture of hemophilia is a boy who falls down. Maybe he's riding a scooter and he's got a swollen knee and he's very painful. And this has happened a lot of times, right? So we'll get into it. So hemophilia is another coagulation. It is primarily this time a coagulation cascade defect. Okay, so we can be deficient in factor 11, factor 9, or factor 8. All of three of these are in the intrinsic pathway. These do not affect the extrinsic pathway at all. So for every hemophilia question, the PT will not be affected at all, ever. Okay? And yeah. Okay, so some general information about hemophilia. Like we just said, or just saw, it's an intrinsic pathway coagulation defect that prolongs the PTT. The types and inheritance. Hemophilia, the deficient factor, what is it? It's 8, and it's an X-linked recessive disease. Hemophilia B, what's the defective factor? That's 9, and 9 is an X-linked recessive disease as well. So if a woman has one copy of these genes, does she have hemophilia? No, because it's recessive. A woman would need 2 copies for it to be clinically detectable. And really, I was told that, that hemophilia doesn't even become symptomatic until you have only 30% of normal function. So if you have 50% of normal function of these factors, you won't even know. So I thought that was interesting. Hemophilia C is the tricky one. We don't see it hardly at all. And it is a deficiency of factor 11. And it is autosomal recessive, unique from its brother syndromes. Hemorrhage is common in hemophilia. People bleed. They bleed into joints. They bleed at their gums. They bleed, or they bruise easily. They bleed after going to the dentist is a common thing. They get a tooth pulled and they just can't, they just keep bleeding. They keep oozing. They bleed after, trauma or surgery, like oral surgery or dental procedures, like we just said. And treatment is desmopressin. Not so much anymore, just the same kind of thing. If, genetically there's a defect, giving desmopressin is not just going to make it come out of nowhere, right? Desmopressin causes it to be released from endothelial cells. But, excuse me, as well as, it's not also the liver, actually. So, but, yeah, desmopressin is just not just a cure-all, right? You have to actually have the genes to make it for desmopressin to be helpful. Really what they use is concentrate of the missing factor. Now, there is a new treatment, and I think this is cool, and this speaks to the marvel of modern medicine. It's a monoclonal antibody known as imicizumab, or Hemlibra is the trade name. So it's a monoclonal antibody used for the treatment of hemophilia A. Monoclonal means there's only one type of antibody in there. So, and you can only use this for hemophilia A because it is a mock factor 8. So the action of factor 8, it brings factor 9, A, and 10 together, and that continues down the coagulation cascade. Hemlibra and factor 8 deficient people, also known as people with hemophilia A, when that's gone, Hemlibra does the same thing, brings factor 9A in contact with factor 10, and then it allows you to bypass this step of the coagulation cascade. So this and this come together, boom, activate to 10 to 10A, and then that can continue the pathway, and you can form a stable fibrin clot. So the half-life of it is 4 weeks. You dose it once weekly, subcutaneous injection. You do that for 4 weeks, once a week. And then that varies depending on your severity of disease. If you have basically no factor 8, then you would get it dosed more frequently. If you have partial or parts, then you get the injection less frequently. So something noticeable or an interesting fact about Hemlibra is that it has lower binding affinity for factors 9A and 10 than native factor 8A. So it has less strength to bind to these two factors. And so when you can, and when you do give Hemlibra in coordination or conjunction with or combination with clotting factor concentrate, you do not have overcoagulation as a side effect, which I thought was cool. So emergent treatment of hemophilia. So prophylactically, you treat hemophilia with concentrate because of hemarthrosis. Because hemarthrosis goes in, blood goes into the joint. Blood contains this protein called hemosiderin. Hemosiderin contains iron. Iron is an oxidative agent. Oxidative agents damage the joint. The joint, the cartilage gets damaged. Cartilage doesn't regrow. People get arthritis, early onset arthritis with hemophilia. If they recurrently bleed into their knees, they get arthritis at early ages. So you do treat hemophilia prophylactically. Von Willebrand factor, you do not have that problem, so you generally treat around known stressors. So if you know a woman or a man, a woman or a man is going to have surgery, then you give them concentrate of von Willebrand factor. But you don't continuously supply them with von Willebrand factor. But you do in hemophilia because it's prophylactic against hemarthrosis, bleeding into the joint, getting arthritis. And but in the emergency room, if you're in the emergency room, and we got hemophilia A and hemophilia B, and let's say they come in with major severe bleeding. Well, what is that? So we see the asterisk come down, boom. Examples of major bleeding include bleeding affecting the CNS, airway, hip, deep muscle with neurovascular injury, or the abdomen, or bleeding that cannot be controlled with local therapies, or bleeding necessitating transfusion. So there we go. We have our criteria for what constitutes major severe bleeding, and the goal is to raise the factor level to 80 to 100% of normal. Okay, and then contrast that with just run-of-the-mill hemarthrosis, less severe, less life-threatening. The goal is to raise the factor level up to 40 to 50%. Remember, hemophilia is symptomatic at about 30%, so raising it to 40 to 50% should help correct the issue. You don't want to go too high because then you run the risk of overcoagulation, but you kind of want to get the sweet spot. So something my professor did point out about this, and I'm glad she did, hemophilia A and hemophilia B, generally when you're replacing, they go, well, how much do you want to give? How much do you want to give? Well, you know that in hemophilia A, you usually want to give about half of whatever you're giving for hemophilia B. So factor 8, you give about 50 units per kg for major severe bleeding, and then you give about 100 of, or 100 to 120 of factor 9 for hemophilia B. So that was kind of the thing she wanted to point out, is that knowing that rule of you want to give like a 1-to-1 replenishment in hemophilia B versus a 0.5 or a half to 1 replenishing. So let's do the chart here. Hemophilia. What is the bleeding time? Excuse me. In hemophilia, increased, decreased, or normal? Well, let's think about it. Hemophilia is a intrinsic coagulation factor, intrinsic coagulation cascade defect. Does that affect the bleeding time? No, it does not. The bleeding time is affected by platelet plug formation. If the platelet plug forms normally, then the coagulation cascade, the bleeding time is normal. Okay, but the clots are weaker, so that's why people bleed more. Okay, they bleed more because they have weak clots, because they don't form that strong fibrin clot over it, as well as people who do not have hemophilia. What is the platelet level in people with hemophilia? If you said normal, you are correct. It does not affect platelets. It is a clotting factor disorder. You could argue that because the clots are weak and the platelet plugs are weak and always having to reform, that you might be consuming platelets chronically. And that does make sense, but the body makes platelets at a rate that is faster in general than what's depleting them, unless in the settings of like severe trauma, where the platelets will be low anyway because of the trauma. So it's generally not affected by that. So the platelet count is normal. The PT, the prothrombin type. Is hemophilia a defect of the extrinsic pathway? No, it is not. This is normal. And the PTT. What is the PTT in hemophilia? It is prolonged or increased. So if you enjoyed this, please subscribe or like or comment. Let me know that you watched it. Give me feedback on things that I could do better, things you thought might have been wrong. And these are my references. I didn't include up-to-date or the clinical trial for emicizumab, the monoclonal, but they're there. So, all right. Thank you for watching.